Hi, I am Dr. Keisha Davis, founder and CEO of AskPath. We are here today to answer your questions about COVID-19. The novel coronavirus is part of a large family of viruses that causes illnesses ranging from the common cold to severe acute respiratory distress. The novel coronavirus is known as COVID-19. The actual virus is actually known as SARS-CoV-2, which stands for Severe Acute Respiratory Distress Virus 2. The virus that causes COVID-19 is not airborne. It's actually transmitted through droplets generated when an infected person coughs, sneezes, or speaks. These droplets are too heavy to hang in the air. They quickly fall on the floor and surfaces. Therefore, it's important that we wash our hands, keep our distance, and maintain all the guidelines during this pandemic.
It is possible that around 20% of the U.S. population will contract COVID-19, and 0.5%, or around 327,000 people, will die. This mortality rate is around 9 times that of a typical flu season. The U.S. currently has around 925,000 staffed hospital beds and approximately 46,500 ICU beds. These numbers will simply not be enough if we expect that over 200,000 patients may simultaneously need intensive care. This is why we must engage in every preventive measure possible now. The goal of containment is to track every case of the disease and end its spread. Quarantines are one of the tools used to contain. Now, in our current age of global connectivity, it may be difficult to institute effective quarantine measures. Mitigation is more easily attained. The goal of mitigation is to slow the spread of the disease. It focuses on protecting the most vulnerable from the effects of a disease that is already widespread throughout a community. And by reducing the number of active cases, healthcare workers are better able to respond without being overwhelmed.
There are many causes for cough and fever. During this time, pathologists are still seeing many biopsies from patients with other things, including cancer and other types of infection. So it's important during this time, even if you don't have COVID, that you are doing your regular checkups and always staying in touch with your physician.
There is some anecdotal evidence that remdesivir, a failed Ebola drug, may be effective. The HIV drug Kaletra is also promising. China approved the use of favipiravir, an antiviral drug used for influenza, as an investigational therapy for COVID-19. There are the antimalarial drugs chloroquine and hydroxychloroquine that are sometimes used in combination with the antibiotic azithromycin, which have also shown promising results in several studies in China and France. Clinical trials are currently underway in many countries to test the drug's safety and effectiveness. No vaccines are available yet. Though there are more than 11 in development, none are expected to be available to the public for at least a year.
Plasma is the liquid portion of blood that contains proteins such as antibodies. Antibodies are used to fight infections. Convalescent plasma is the plasma that is recovered from individuals that have finally gotten better from an illness. We are believing that with COVID-19, the convalescent plasma may help sick individuals. It is important that convalescent plasma is recovered from an individual after they have recovered from the infection. Also, investigation is still necessary to see if convalescent plasma really shortens the duration of illness, reduces morbidity, or even prevents death associated with COVID-19. If you are healthy and interested in donating blood, the FDA encourages you to contact a local donation center to make an appointment. It's important during this time that we try to keep our blood supplies up. There are a lot of rare blood types that need to be replenished. Also, if you are concerned, there is no reported blood transfusion-associated COVID-19 disease at this time. Remember, COVID-19 is a respiratory illness. so therefore your risk of getting it from a blood transfusion is very low. Also, as long as you follow precautions, there's no chance that you will develop COVID-19 while you're at the donation center.
It's not that being Black as an intrinsic characteristic makes us more susceptible to COVID-19. It's the combination of societal factors. African Americans and Latinos are being exposed more due to having low-wage jobs or because they're essential personnel and they have no choice. Grocery store clerks, custodial staff, bus drivers, people who take care of others in their home are more likely to be exposed at home, at work, and on public transportation. We know that certain underlying comorbidities such as diabetes and asthma, just to name two, increase the risk of severe outcomes to the novel coronavirus. And we know that there are high rates of these illnesses in the African American and Latino communities. But we must recognize the societal factors that contribute to the prevalence of these comorbidities. There is a distinct correlation between urban areas with higher pollution levels and asthma in the residents of those communities. We also know that in food-scarce areas, where you have to take 2 or 3 buses just to get away from fast food places into a decent grocery store, can be a hindrance to maintaining a nutritious and well-balanced diet to stave off obesity and type 2 diabetes. Add on top of that, a lack of access to regular health care for a variety of reasons, and now you have a population where poorly or even uncontrolled diabetes and asthma are not surprising. There are inequities that have existed in our communities for decades. This pandemic is just now shining a light on it.
During this pandemic, testing has been a concern. Initially, only the federal government was providing testing, but the first test had manufacturing errors. As the pandemic grew, the federal government finally allowed testing to be open in hospitals and commercial labs. LabCorp and Quest are 2 of the main labs doing testing, but they've even had a backlog, sometimes as much as 88,000 tests. Turnaround time can vary from a few hours to take the test, but up to 5 to 7 days to get a result. Also, test supplies have been a main issue. Having the test kits, having the extraction kits, having the correct swabs, and also having the personnel are main concerns. Hopefully, as this pandemic grows, we're able to provide the testing so that everyone can get tested and we can make sure that this virus is under control.
Nasopharyngeal swabs, not throat swabs, should be submitted for PCR testing. If a nasopharyngeal swab is not inserted properly into the nasopharyngeal space and only reaches the nares, it is likely the test will yield a false negative result, even if the patient is infected with the novel coronavirus. Ideally, a lower respiratory tract sample such as induced sputum or bronchoalveolar lavage should also be submitted, and serum samples can be sent as well.
The type of swab that is used for collection is important. The FDA recommends that a flopped swab is used when available. The CDC does not recommend that a calcium alginate or wooden shaft swab are used because they have substances that can inhibit PCR or inhibit the virus. With COVID-19 being so new, there are no FDA-approved tests at this time. However, the FDA has several EUAs, which are emergency use authorization tests. Right now, PCR molecular tests are being done. If you want a complete list of all the places that have emergency use authorization tests, please look on the FDA site. Please be careful and make sure you are using a test that is approved.
PCR is the gold standard because it is highly sensitive. It is the preferred test for COVID-19 workup, especially in non-endemic areas. However, if the pretest probability is very high due to high disease prevalence, and if many cases of the disease have already been confirmed by nucleic acid testing in an endemic area, PCR may not be necessary, especially if time is a consideration. PCR can take an average of 2 to 6 hours to run, though there are some machines like the one from Cepheid that can take as little as 45 minutes. Now, this may be an opportunity to use an immunoassay test. The Chorus Bioconcept test takes 15 minutes to detect viral antigens. The downside is that the test sensitivity is only 60%. But these type of tests generally have a good specificity, meaning they are unlikely to show a false positive. So a positive result might be helpful for detecting a positive patient, but a negative result won't necessarily mean that the patient is not infected. Most laboratories use PCR. The tests amplify and detect viral genomic material. The majority of PCRs target 2 different amplification regions. Now, recent studies indicate that viral load peaks in the first week of disease onset. Although viral RNA can be detected during the second week of disease, the viral load is low. PCR can be positive in some asymptomatic and in recovering patients. Now, despite high sensitivity, a negative PCR is not sufficient to exclude COVID-19 in patients with a high clinical suspicion. According to the WHO, a single negative test does not exclude infection with the novel coronavirus. Patients with a typical clinical presentation or clear epidemic indications should receive clinical treatment and case management, even if PCR is negative at 1 or 2 time points.
Testing can be put into 3 groups: clear wave testing, which is point of care testing, moderate complexity, and high complexity. All of the COVID-19 testing at this time is molecular based and is high complexity. The FDA recently clarified that when it grants emergency use authorization for a point of care test for COVID-19, it will be deemed clear wave. As of now, molecular-based testing is a definitive testing for COVID-19 if you have a patient you are concerned about disease. However, antibody testing or serology testing is in the works, and there are many places that may be offering it soon. You must note that a negative result does not rule out a SARS-CoV-2 infection, particularly in those who have been in contact with the virus. Follow-up testing with molecular-based testing is definitely recommended to rule out infection in these individuals. And results from an antibody test should not be used as a sole basis for diagnosis. Also, a positive result does not mean that the patient had SARS-CoV-2. There are also going to be positive antibodies in a non-SARS-CoV-2 coronavirus, such as HKU1 and OC43. Please follow the FDA for updates on available serology testing.
The American Medical Association announced a new CPT code to report COVID-19 test results for Medicare and private insurers, H7635. CMS also created 2 billing codes for laboratories to use when testing the virus. Labs can use HCPCS code U0001 if they're performing the CDC test for COVID, and code U0002 for non-CDC laboratory tests. The Medicare initial payment is $36 for the CDC test and $52 for the non-CDC test. More data is needed to say for certain. Infected people can test positive via PCR, a molecular test which detects the virus's RNA, for weeks. But this doesn't necessarily mean that that individual is contagious for weeks. There are PCR tests suggesting that people with mild disease can be positive for 2 to 3 weeks. You really need to determine if these individuals are actually still contagious during that 2 to 3 week period. The WHO is still recommending that people who have been exposed quarantine for 14 days. This is because most people who are infected with COVID-19 will develop symptoms within the median time frame of 5 to 6 days. The threshold for achieving herd immunity, the fraction of the population that needs to be immune to a disease to make person-to-person transmission extremely unlikely, varies virus by virus. With measles, for example, that threshold is high, 93 to 95%. However, for the novel coronavirus, that estimate is much lower, between 50% and 66%. The bad news is that this means that at least half of Americans need to become infected or vaccinated before the population reaches herd immunity. Even in the hardest hit countries like Italy, it's estimated that less than 10% of the population has been infected. In the US, it's estimated that 1 to 5% of the population has been infected. The prospect of becoming infected is very dangerous for members of vulnerable populations who are susceptible to more severe outcomes to COVID-19. There's also emerging evidence regarding reinfection, which makes attempting to reach herd immunity a very dangerous idea.
Pathologists all around the world are working hard to look at biopsies of patients that have COVID-19. Biopsies can be done either by a patient that currently has it through a swab, through an actual lung biopsy, or post-mortem. Right now, the histological findings are mostly in the lung, and they are similar to those found in the previous SARS and MERS. Most of those findings are called diffuse alveolar damage, which is seen in those patients that have acute respiratory distress syndrome. The changes include hyaline membrane formation and pneumocyte hyperplasia. Other organs that some findings have been found in have been the liver and heart. However, those findings can also be attributed to organ failure and other causes. This is a very difficult time. Pathologists, as part of the healthcare team, are working hard to try to fight this pandemic. I'm Dr. Keisha Davis, pathologist and founder and CEO of AskPath. AskPath is a resource for pathologists to give information to clinicians and patients about laboratory testing, the importance of validation, and biopsy results. During this pandemic, it's even more important that everyone understand the value of testing, the importance of protocol, and the results that we give. Again, I'm Dr. Davis, founder of AskPath, and I hope to help you with these questions that we are answering.